This is the Global Podcast Network, where executives and professionals connect, share, and inspire. Stay tuned for the conversations that drive success.
We are honored to have back Thomas Perron, our private practice psychiatry, owner of his own company, and it's Perron Psychiatry, based out of beautiful New York City. He's back with us today to talk more about how he can help you in the office, or maybe it's a virtual appointment, evaluating, treating, dealing with medication management, and of course, helping you diagnose different assessments. So, first and foremost, thank you for being here and helping so many people throughout the tri-state. How's it going?
It's going great. Thank you so much for having me back. I really do appreciate the ability to be able to talk about some of this stuff because as a kind of a psychiatry nerd, I think I wear out a lot of my friends in conversation. So being able to come here and talk is a lot of fun for me.
Perfect.
And certainly, like you mentioned, Jill, about providing care throughout New York. I mean, we're lucky. One of the things that came out of the
Pandemic.
right, the misery that it was that we were able to develop systems where we can virtually treat folks and then provide better access. Because really, particularly, not so much even in New York City, where we have a lot of providers, there's still a giant shortage of people. So, like in our practice, what we do is see people in person, like the old-fashioned kind of antiquated system where you come in, you see people, and you go home. But we also have a robust virtual arm, and that allows us to access patients and have patients access us that may be struggling. A lot of times patients will even have to go to their primary care providers to try and get treatment, and getting an appointment and seeing somebody like me, a nurse practitioner, a psychiatrist, even therapists, sometimes can be kind of challenging. If you're feeling bad right out of the gate, if it's difficult to get the appointment to start to feel better, that becomes a problem. And it's easy to kind of throw your hands up if we're already depressed and kind of feeling that way.
Yeah.
The difficulty in trying to find somebody to help, multiple appointments, insurance, and then cost of care is there's lots of reasons why people have a hard time accessing this care, despite the fact that we know so much more about it. And so I think, back to the point that you mentioned about the wide array of treatment modalities, is that now we do offer those. And even in the community setting where I've done most of my work, I've done in the community setting where I've worked in shelters and emergency rooms and in community clinics. And I've had my own private practice for many years running parallel to that. And I focus primarily on that now. And it's an in-person and virtual setting like we're talking about. However, there still is this tremendous need. It's even with all resources, it's difficult to get an appointment with a private person. And many times you can run into some of my colleagues who are very expensive. And so with all that being said, somebody who is struggling with depression, who may be functioning fairly well and have commercial insurance and have everything that they need to access this system, may still have problems accessing this system. So if we take another layer down and we take a look at chronic and persistent mental illness and the way that affects not only just the patient, but families. And then the access to treatment, when we start to look at folks with lesser resources, folks who aren't insured in the commercial markets. When we look at the Medicaid and Medicare and Affordable Care Act programs, many private practices don't engage in those systems. And so what do you do for the millions and millions of folks who just alone in New York City? And that's one of the reasons that we were talking a little bit earlier about accessing systems, is that not only is the commercial system difficult, however able to be accessed, the community system which I came from is one that's in flux, and we see it in the news. Here in New York City, we have a lot of talk about homelessness and mental illness. And it's now on the forefront of our political landscape because we have a mayoral race in New York that's gaining a lot of national attention. And one of the things about it is that there's all kinds of politics, and I'm not going to get into the politics, but one
I
thing
know.
that keeps coming up in these discussions in my town's mayoral race, because it's such a big town and it is making national news, is that on both ends of this political spectrum, homelessness and mental illness are both on that agenda.
I was
And that,
watching that on the news this morning and about how they've been doing so well, at least in the subways right now, helping over 4,000. They were talking about those, some of the homeless and the people that need mental aid and all the over 4,000 been helped this year. The mayor was,
right,
I just was watching this morning, so it's
right,
really
right,
refreshing
right.
my memory. Go ahead.
Right. And I think, with that point, right, that
Hmm.
what we're seeing is that, of course, it's exciting. There's one political spectrum here and there, and everybody's yelling, and it's very, very exciting stuff, the
Yeah.
politics these days. But what's coming out is that, at least in our local race here, is that mental health and homelessness are being connected in a way that hasn't really been publicized to the degree that it needs to be, I think. Because one of the issues that when we talk about these things
Hmm.
and when these politics come up and they talk about getting homeless off the streets and into the care that they need, that sentence in its own right is very expensive.
Yeah.
What we're talking about is getting a chronically, persistently mentally ill person from street homeless into a shelter, from a shelter,
Hmm.
assessed, medically evaluated, psychiatrically evaluated, treated, and
Yeah.
then housed, and then kept in housing. Now let's
Oh,
just put this, let's just add a little spice to this equation and add a little substance abuse in there, or alcoholism, and on top of the comorbidities. And so now we have what I know after 30 years is a classic presentation of a New York City homeless resident,
yeah.
that we have been struggling. In some cases, I've
Hmm.
known some of these patients for decades. I will see them
Wow.
in Washington Heights at a shelter, and then as months or even years later, I may run into them in a shelter in Brooklyn, and they're still in their condition. So the idea that we have this system that's running and constant, and politicians talk about it and news talks about it, and as the holidays come around, agencies will ask for donations to help, and as this becomes more and more uh, um, known, available,
Yeah.
we have to then take a look and see, well, what can really be done. And
Yeah.
as somebody who has spent 30 years at the patient's bedside.
Hmm.
I have written policy. I have worked in agencies. I've been lucky enough
Yeah.
to have a systems level approach. But at the entire time, I've been with the persistent, chronically homeless and mentally ill patient for 30 years. And what I can tell you is that there is a system in place, and it has to be employed a little bit differently. We have public systems and clinics here. I have managed many of them over many times, and now, excitingly enough, Harlem Family Services has contracted me to improve access to mental health
Hmm.
psychiatry here in Harlem, in Upper Manhattan, and there'll be a brand new clinic with very, very famous psychiatrist who is lending his expertise to our agency's newest clinic, and Harlem Family Services will be,
Yeah.
I think, a beacon of how the system that is in place will be able to provide increased access to folks with no regard to their ability to pay. And now when we look at that, that's a big loogie. That is a lot to
Hmm.
say when you can open a
Yeah.
clinic in Harlem and treat everybody who walks through your door, without any obstacles that we talked about: the commercial marketplace, the insurance eligibility, the co-payments, the falling through the cracks, the difficulty in it that it can be. So all of those things, if we remove those to our patients who are in our shelters, who are on the streets, and they can
Hmm.
access our systems in Harlem Family Services, and Harlem United, or at Housing Works, or the
Yeah.
multitude of public systems that are out there. If
Yeah.
they are run properly, this becomes not only, and again, in very small pieces, we make changes for the patient, we make changes for their family, We make changes then for their community, and then we can then show that we've made a footprint so that an agency like Harlem Family Services can then show a repeatable model as we move forward, and hopefully, despite the political landscape, be able to push the button and very effectively manage those community systems. And that I think is a big part and complement to those of
Yeah.
us who are trying to improve access.
Beautiful. And for those that don't know, I just want to point out you've been in practice for what, over almost 20 years now?
About
Uh,
20, I'm in my 28th year.
oh
Yeah,
my goodness. And
it's
you are a
true.
board certified psychiatric nurse practitioner. So
That's
you
right.
really have a lot of experience with this.
Sure.
And just curious, you work with, is it adolescents to adults, or what is the age range?
Sure. No, real little ones should probably see people who specialize with real little ones. There's lots of different assessments that have to go on in that regard. But I see children and adolescents and adults. And at my private office as well as the community settings that I work in. And in many instances, it's kind of a general approach. So when we look at, just like any other place, when in my practice, what I practice is general psychiatry, I do unwittingly have fallen into a specialty because I've treated so much post-traumatic stress disorder over my career. I've become somewhat expert in the amount of
Of
PTSD
course.
that I've seen. However, I don't really specialize in one particular area. I do work with some specialists who will work in a specific modality. So a place like mine or a
Mm-hmm.
clinic like mine, um, uh, more than anything else, like you mentioned at our opening, is the diagnostic piece, is
Yep.
to get to know our patients, is to see what they need and what it is that we can offer them. And that level of triage, if you will, gives us a kind of the launching off point to then see if we are the right provider. If someone comes in and they have a very specific problem, that our best idea might be to find the proper referral for them to help them land in the right place. So although we may not be their treating provider, we
Yep.
certainly are able to make an assessment and at least point them in the right direction. So that a patient who engages in this system, whether it be in my office or my community clinic at Harlem Family Services or another private office, is that the entire system should be welcoming, right? So that it disarms the patient. Many times, patients are nervous and scared to come into the office, and sometimes afraid to tell us that they're feeling so bad because they don't know what we'll do with that information, right? Do we call an ambulance? Am I going to lock them up somewhere, or what are we going to do? So there's all those things that make it so difficult to access. So a general office like mine at least gives an opportunity to assess a large degree of patients, and if we can help, we put our plan of action into place immediately. And if we are not going to be the treating providers, and certainly we have a very robust portfolio of providers that I've worked with over many years. And so we can at least point somebody in the right direction and certainly help them land in that way.
Yeah.
This requires a great deal of empathy. So if somebody comes to me and they can't afford treatment, or they're not I'm not on their insurance network or such, it still behooves us to be human, right? And to take our foot off the gas and
And I wish
to
more
help
people
us.
were like you, but
Oh,
that is so
no.
kind. No, it
Oh,
is because not everybody is, but you clearly care and want to help people. And I
sure.
mean, sets you apart. I've talked to people who've done your type of work, but no, there's something about you that comes across, and you were a seriously genuine, kind person. And I love that you're here to help so many people.
Well,
And
I will tell you this. I know I'm going on and on a little
it's
bit,
okay.
but
It's okay. This is your
one
show. Don't worry. Go for it.
one of the things that I will tell you is that this is a very difficult job.
Ah,
It's very rewarding to have somebody get well and
Yes.
to feel like you had a role in
So
that.
true. Yeah.
It really is. It's quite rewarding, but it does zap you when you spend a lot of. As a matter of fact, I had a discussion with my wife about this, and that's why I wanted to bring this up because I couldn't do this work without my wife. And everybody has to find their own thing that keeps
Oh,
them solid, right? Many times we have to go as clinicians, we have to go and get supervision from other clinicians. We have to talk to them. And because when we hear something and we're actively listening, we're applying science and we're trying to come up with a diagnosis and all the other stuff, somewhere along the line, something's going to kind of gut punch us, right? Because we're human. And when we try and be helpful and also try to be stoic and try to provide care in a way that is disarming and empathic, but comprehensive is is a difficult thing to do over
yeah.
time. And sometimes you'll get great days, and unfortunately, those are far and few between. So what I think, and this is true, I think for patients too, is that there's a great source of support that we have to make sure that we're actively seeking. And for me, it's my family, it's my wife. Without her guidance and supervision, and being able to lean on her when
Yeah.
days are difficult, and many times, like any other job, right? If somebody has a bad day, the people
Yeah.
around us should look after us. This for me has created a little bit extra demand. I'm a little bit of a needy guy. If I need attention, I get a little pouty, and so I don't have a problem accessing accessing attention when I need it. But I've been fortunate and that I have really good colleagues and supportive folks around us,
Yeah.
and as well really strong supportive relationships. And I'm fortunate for me to be married for 30 years to somebody who was tolerating me and put me in a position that I can help today. But not many of us have those things, and patients as well. So one of the things why I bring this up is that not only to give a shout out to my wife, who's
Oh, it's beautiful. I
wonderful.
love
Oh,
her.
she's
That is
awesome.
so
Oh, she's
sweet. No,
awesome.
that is
She's
so
awesome.
amazing. See,
Oh no, guys, she's the smartest woman I've ever met. And my goodness, I can't. She's an angel for having to put up with me. But
oh,
in the context of the way that I think when we look at resources, is that many times in the day to day of our families and our friends, that we again, if we're feeling bad and we are having trouble accessing the support that we need, many times it's right within our house that we can find that there are, and it is an assessment that we make. Do we have a support network, a structure in place? Because we will employ that, and very much the way I employed my support structure during my studies and preparation. And even now, as I teach, my wife is a professor, and so she helps teach me how to teach as I teach my students. And so in those relationships, I think is where we can find some help to be able to access these systems, whether it be friends or families or colleagues. If we see somebody who needs help, or if we need help to try to extend something that is helpful and human to get us into the next step. So that if we're employing family and friends and our spouses and our communities, and hopefully navigating systems that are as a little bit kinder, like my system at Harlem Family Services, or like my private office, where we can provide access in a way that provides treatment, but in a way that can hopefully provide it without stigma and some comfort, and applying support and family and community. Those are all important things.
hmm. Beautiful. Well, thank you so much. We still got 7 more minutes left in your show,
I
Thomas. What
got you.
else do you want to share for today? And by the way,
Well,
can I ask, what does your wife do? Just to be so kind and
sure.
compassionate, and if you
No, no,
don't
no, no.
mind.
She's not. My wife is a professor at St. John's University.
Oh, wow.
Yep, she teaches in. She's a developmental neurophysiologist. She is, yeah, she's very, very smart. And So she studies what is called axon guidance. And so when a nerve cell grows and develops, there's a way that it's being told where to go and how to bend. And so my wife studies the molecular workings of that in all kinds of models. She's well published. She teaches out in the toxicology. She got tenured some years ago. She's wonderful. Jeanette Perron is Dr. Perron. She's wonderful.
Amazing.
Yeah, she's one of the most amazing women on the planet.
Beautiful. All right. Thank you so much. It's like her show. You got to make sure you make clips for her. Baby, I talked about you all day. I love you. I adore you. Everyone
Absolutely,
knows.
yes. I'll have to chase the text message that I sent her with
Oh,
telling her that she'll be very embarrassed, I'm sure. But it is the truth, and I think that those things, as much as it is a nice opportunity to talk about my wife, the idea when we kind of tie this up is that um, when we're feeling bad, even in a setting where we have really good people around us, symptoms sometimes can make us feel very alone, even if we're
yeah.
in a crowd of people who love us very, very much. And sometimes treatment is about doing the things that we know are good for the patient, that the patient really does not want to do because depression is getting in the
Yeah.
way, or anxiety or schizophrenia or those things. And sometimes when we look at it as a community, as a family, is that our loved one, our friend, family member might be behaving in a way that is really distressing and might even be mean or irritable and can affect relationships and make us standoffish or make us want to leave. Like, oh, forget this. I'm not putting up with
Of
this,
course.
right? But if it was diabetes and they were very sick with diabetes, we wouldn't run from that, right? And so I think that to separate those symptoms, to understand them, and to be able to help families understand how to better help their family member, with
Yeah, of
us as a
course.
partner is I think another important aspect of the way that we can treat, because we have to support a family who may bring a family member in who needs help, that does not know they need help or really does not want it at the time. Many times when I've seen patients in those acute throes where a family has mobilized and dragged a
Oh,
patient to
yeah.
treatment, um, uh, the patient is in a difficult spot, and it's the family that becomes the client and who we engage, and as a system, and employ those supports. So me, lucky to have the support that I have. Um, and if something were to go sideways in any capacity, I would want any of my providers to access my support status, systems, right? To access my family, because and because that's good practice. And that's, I think, one of the other aspects of this is that not only do we provide access to patients, but and communities and systems like we've talked about,
Yeah.
but it's the idea of a supportive network of family or friends, colleagues that many times are going to be key to bringing everybody in so that we can get a crack at helping them.
Beautiful. Well, thank you so much.
Oh,
And
no problem.
I want to thank you for always being here on time and really eager to help so many people the way you do. And to
Thank you.
kind of sum up today, your services to someone out there who may be in need, just tell us a little bit about, what should they do? How do they contact you? And
Sure,
of course, it's a scary thing sometimes, and you don't
sure,
know. It's how to
sure.
trust someone and build that rapport with someone.
So in accessing our office, tperronpsychiatry.com, you can find our website is there, Psychology Today, ZocDoc. I'm also now available through the Harlem Family Services website. Primarily the easiest way to get me is tperronpsychiatry, tperronpsychiatry at Gmail. or 631-743-6647. And that number can be texted or emailed or called. Many times you'll get a voicemail. And in the morning, most of the time in the morning time, I have admin time to be able to square anything away. So through our website or email or phone at any time, we're more than happy. We many times are a little busy, but we certainly get back pretty quickly as I can.
Perfect. Thank you so much. And how do we contact you, darling?
And at any time, Perron Psychiatry at Gmail or 631-743-6647.
All right. Thanks again for being here
No
and
problem. Thank you, Jill.
getting through, this nor'easter that we're dealing with here in the Northeast.
Yes,
And
be safe.
stay inside, stay warm, stay safe, and we'll talk next week, I hope. Okay.
Thank you, Jill. Have
Thank
a
you
great
so
day.
much. I
Take care.
appreciate it. You too. Bye-bye.
This is the Global Podcast Network, where executives and professionals connect, share, and inspire. Stay tuned for the conversations that drive success.